So the earlier sessions?
Okay, very good. A lot of questions.
That's
And
good. Thank you.
what I've done also is I've created an online link and so that participant can ask question and later on I forward you any questions that on your lecture. I think
Okay.
uh, I think most of the students are here. If you want, you can start earlier.
Yep.
And can the students actually just inform your colleagues that maybe came out or anything to just come in so we can start the lecture. Okay, just a brief introduction. Dr. Kavi, senior member of AFPM, okay, has been around for many years, okay, and you will see him in various phases of your study, okay, until the very last, except before you become complete your journey as a specialist. So without further delay, I'd like to welcome Dr. Kavi to give his lecture on prescribing and referrals.
Thank you, Dr. Naveen, and the kind introduction. And let me start. Are you all there, everyone? Can you see my slide?
Yes,
Yes,
doctor.
doctor.
Okay,
Yes,
right.
doctor.
So I'll be going, and if at any one time you feel that I'm going fast, you can't understand, you can raise your hand. Otherwise, you can keep your questions at the end of the session. Is it okay?
Okay, doctor.
Okay,
Right.
doctor.
So some of times I'll be asking questions, just we'll so that it's interactive, and then in this sleepy afternoon we don't doze off. Okay, right. Good afternoon, and let's delve into prescribing and referral. And the objective of this webinar is at the end of this lecture, you should be able to do a rational selection of drug while you prescribe. What are the good prescription practice? What you as a prescriber, what are your responsibility? Polypharmacy and prescribing, which is very common nowadays. Good referral practice. Of course, there'll be some legal element which you have already did it in the first lecture. So I'll just go touch a little bit on the legal aspect of prescription. Now, there are there are many principles. I just put it into four key principles in prescription. Okay. First is rational and evidence-based prescribing. You all know that, I'm sure that most of you all know how to write a prescription because we learn how to write a prescription even as an undergraduate. And then when we became a house officer, we learn from the medical, our superiors, our medical officers, and then as you became a medical officer, you learn from your registrar and the specialist and from the consultant. I'm sure many of you all have written thousands and thousands of prescription. What I'm going to do is just go through the go through uh, what is prescribing, what we do and how to prescribe. Now, when we come to rational selection of a drug, you must, there are 8 principles which I will go through it later part of this lecture. And you should choose your medication based on the available clinical evidence or established treatment protocol. Okay, that is the first one. Because when you select a drug, make sure it is evidence based. It's so I will delve on it later. Patient centered. This is very important. Okay, you are going to prescribe a medication. Uh, Nowadays, it's patient centered. Those days, we just prescribe the medicine and expect the patient to continue with the medication, but no more because the patients nowadays they Google, they look into the side effect, and they see whether it is suitable for them rather than you telling them that is suitable. So you need to be engage the patient at every step of your treatment plan, and you have to consider their preferences, especially men. Be careful about the beta blockers, which will affect their erectile function, and then you have to look into the cultural belief of each community and then their lifestyle. Okay, this is very important. Patient centered is important. You can give the best medicine, but then the patient may not be compliant. We are seeing it many times because you can see patients bringing um, a bag full of medicine, but are they really taking it? you need to ask them, ask the patient when they come back. They will tell you the truth. Sometimes they'll tell you the truth. Most of the time they say they are taking it, but majority of time they do not follow the instruction, because if you are going to give too many medicine and it is not patient centered, they may not take. Next is you need to assess the risk and the benefit. Okay, you have to, whenever you're going to prescribe medication for an elderly, whenever you're going to prescribe medicine for a child, whenever you're going to prescribe for the pregnant lady and lactating mother, you need to look into the benefit versus risk. Okay, there are some of the medications uh, may bring risk to the mother, especially in the first trimester. Okay, at least on the first few weeks of conception. So you need to look into that and prescribe. Last but not the least is ethical legal responsibility. You, as the prescriber, is responsible for each and every prescription, whether it's verbal or written or electronic. You are responsible under the Medical Act. Anything you write, you are responsible. So you have to ask yourself whether I need to prescribe medicine for this
Nak tunjuk
patient.
nak jalan.
Was it? Okay, I think you want to jalan leave the session. Okay. Now, avoid unnecessary prescription and ask yourself whether this patient really needs medication or not. And every prescription you write, you should document and keep it. I will go through it, go through these four key principles later. Now, what are the common pitfalls in prescription? There are many pitfalls. First one is insufficient patient assessment. Okay, when a patient comes to see you, you listen to the patient, take history, proper history. So you must take the full history, not only the chief complaint but must ask about whether they have any allergies, whether they have any illness, are they taking any other medications, whether there could be any interaction of the medicine. So you need to ask, and then you start prescribing, because failure to ask about the comorbidity will land you in trouble, because we prescribe NSAIDs for patients with gastritis or patient with a renal impairment. You might aggravate the problem. Polypharmacy and drug interaction. This is another common pitfall. We have seen again and again, elderly, especially this happens in elderly with multiple comorbidity. A patient may have hypertension, diabetes, dyslipidemia, thyroid disease, heart disease. Just imagine you're prescribing 10 to 15 medications in the morning, afternoon, evening. Make sure you ask yourself whether this patient needs, or if the patient comes back and been taking the medicine for the past 6 months, ask them, are you taking the medicine? Most likely the patient may not say. They may say, I just take 2 in the morning, another 2 in the afternoon, and 2 in the night, because it's a waste when you give too many medicine, because they will say definitely there will be drug to drug interaction. So you need to ask about that. Because sometimes patients not only take your prescription, but they might just get some herbal medicine, over-the-counter medications, or sometimes for reasons unknown, they trust their colleagues and their neighbors and their relatives. They might just bring one medicine or one packet of jar full of traditional medicine and say, stop all those things and take this one. This very frequently happens. So you need to ask, do you take any other medicines? Prescribed, over the counter, or any other medicines? The other one is you need to is about illegible. I mean, yeah, your handwriting, because now with the electronic medical record and electronic prescription, this is no more issue, because those sometimes earlier the prescription you write can be illegible. For example, in this case, prescribing Lipitor, which no one can decipher this letter, but it's actually Lipitor 10 milligrams. So you need to write legibly. And two, you also need to tell them, you give him medicine, you have to tell, is it oral? Is it nasal? Is it pessary? Is it an anisole? So you have to tell them, because the patient might just go back, especially elderly, they might just forget. They don't know. So it is important to give them in writing or from their relative. coming back to the pitfall is dosage error, especially in children, okay, and geriatric and pregnant ladies. You have to give medication based on their weight and whether they have any comorbidity, and you have to adjust the dose accordingly. And also for pregnant ladies and breastfeeding patients. As I say, patient-centered. Four is patient-centered poor communication. This is you prescribe medicine, you need to tell them the all about the medicine because nowadays patients read about medicines and disease before they come there. So you need to give clear instruction. What instruction if you're going to give medicine, as I mentioned earlier, how many times to take, what, how to take, what are the side effects. You have to communicate with them and you have to tell them about this side effect and when to come back if they have any adverse reaction. And then ignoring adherence issues, cost barrier. Adherence issue is very important. See, when you look at the prescription patterns, when you prescribe a medicine which is once a day, the compliance may be quite good than a medicine which is given every 6 hourly. Especially Zovira, acyclovir for chickenpox, you are going to give 5 times a day. So the compliance may not be very good. So you have to look into replacing acyclovir with uh, other antiviral, so that the patient's adherence is good, like valacyclovir, famciclovir. I'm just giving an example. Sixth is overuse or misuse of antibiotic. This has been told again and again and again, and we are still encountering this issue because there are a lot of multi-drug resistant antibiotics coming up, especially in pediatric age group. Because if you look at the multi-drug resistance in pediatric age group, it's a big issue now. The reason being the child's immunity is not well developed, and when you give antibiotic and if they do not take it properly and it is not indicated, then they develop resistance. So it's always need to look at shorter, prescribing shorter I mean, once a day for shorter duration rather than longer duration and a broad spectrum. For example, if you want to give antibiotic, probably azithromycin once a day for 3 days would be better than giving cefalaxin, which is you have to give 3 times for about 5 days. So look into overuse, misuse of antibiotic. Failure to monitor therapy. I will touch on this about the follow-up because when you give a medication, you need to follow up with the patient and you have to monitor. Sometimes certain medicine needs monitoring, especially warfarin, because now warfarin has been replaced with newer generation where monitoring is not necessary, but some medication, especially anticonvulsants, need to be monitored so that we can know whether the patient is having any toxicity or side effect to the medication. And of course, prescription errors, which I mentioned earlier, illegible handwriting leading to dispensing error, ambiguous abbreviation, and incomplete prescription omitting key details like the dose, route, and duration. So I will touch on this later. So many prescriptions are often continued beyond the point at which they are beneficial and may cause harm. So this you need to remember whenever you are giving prescription, especially for no communicable disease, you need to really follow up, just review the medications and start de-prescribing medication which are not intended. 1 million people are harmed because of medical errors, and in that, a lot of patients are also affected because of prescription errors. So now, because of our prescription, patient need to recover twice, one from the disease and once from the side effect of the medicine prescribed. It's from William Osler. So always remember to prescribe rationally. So what is the importance of prescription? Prescribing in primary care accounts for 33% of all potentially clinical significant errors. It means nearly 34% of prescription in primary care has some issues. So you and the patient need to work together to improve their health and avoid harm and eliminate wasteful practices. And another statistics, more than 50% of all medicines are prescribed inappropriately. Half of all the patients fail to take medicines correctly. NSAIDs cause, especially NSAID cause over a third of admission due to avoidable adverse drug reactions. And gastrointestinal bleeds are implicated in half of the patient's death in primary care. So always remember this when you're prescribing for elderly, they're very susceptible, even though they might not have gastritis or peptic ulcer disease, because these patients are already taking aspirin for other health reasons, probably for cardiovascular disease, so coronary artery disease. So you need to think twice when you want to prescribe NSAIDs to elderly. So this is our new building. Have you all visited our new building? This is our new building at
Yes,
Putrajaya.
we had one workshop there. Yeah.
Oh, that's
Yeah.
good. And tomorrow there's a marathon run. How many of y'all are joining? Not aware. Or you all still having
No.
the workshop, isn't
Workshop.
it? Oh, okay, right. So we're having a run. About 600 participants are taking part in this tomorrow morning. So that just to let you know. So what is the impact of irrational prescribing? So you might just prescribe and forget about it, but you have to keep in mind what are the impact of irrational prescribing. One is ineffective treatment, because sometimes you might be prescribing antibiotic for viral infection. It can be it won't be effective, or you might be giving a wrong medication for wrong diagnosis because you made a wrong diagnosis. So it's ineffective treatment. Sometimes over treatment of the illness. As I mentioned, you gave too many medication for for one condition. For example, polypharmacy. Okay, or you overtreat the patient. For example, strong antibiotics. Say we are talking about pharyngitis, a simple penicillin group of drug. If it is strep A beta hemolytic pharyngitis, penicillin or amoxicillin group of drug should be okay. You don't have to give them something like cefuroxime or third generation penicillin group. Okay, and when you do not give a proper prescription, that leads to prolongation or worsening of the symptom. Can be because of the side effect of the medication itself. As you remember, amoxicillin, other some of the penicillin group can cause diarrhea. Some can cause adverse drug reactions. So you have to think of it. And also causes distress and harm to the patient. It also includes it increases the financial burden, increases the drug resistance, increases adverse drug events, and increase morbidity and mortality. For example, some of the medication can cause morbidity and mortality and loss of patient's confidence in the doctor. Sometimes patient comes to see you, but they are not happy the way you have treated, because you would have seen patient coming from a different doctor coming by and say, doctor, I don't think so. The treatment is good. I just want to get an opinion from you. What do you think? This is on the medication. And so I'm sure you would have encountered that. And last but not the least, remember the legal implications. I'm sure Mr. Rajan, the lawyer, told you about the legal implications about the malpractice. But even if you do not prescribe properly, you are in trouble too. There are a lot of legal implications, because sometimes, recently, there was a case in New Zealand where the doctor had prescribed morphine for palliative care, but the prescription was more, the dose of the morphine was a bit more. Even though it's an elderly patient, but 71 years old, patient died, they're suing the doctor for that practice. Another case, you all know that very common is ivermectin. Have you all heard about ivermectin during COVID? There were some doctors who were prescribing ivermectin, and that was a legal issue. And right now, even in New Zealand, there's a doctor being sued for using ivermectin for COVID. in 2021. So whatever you prescribe today, don't remember you have prescribed today, but the legal action can take place anytime after that. That's why you need to be quite careful what you're giving, and it has to be documented. Now, as a primary care physician, many patients present with undifferentiated, they will just come with, doctor, I've got stomach pain. Patient, doctor, I've got headache. But then you need to really ask them, okay? You need to really get their trust. If you don't get their trust, you might miss the boat. For example, patient with epigastric pain. This is very common problem. Patient with epigastric pain, especially elderly, comes and then you examine, you don't take proper history, you prescribe MMT, patient comes back with inferior myocardial infarct. Have any one of you all experienced this type of problem? That is misdiagnosis. Even though you have prescribed rationally for gastritis, your diagnosis was gastritis, and you prescribed antacid and proton pump inhibitor. To your knowledge, it is correct, but your prescription is wrong because the diagnosis is wrong. Have anyone encountered this type of problem? I've had patients who have come with epigastric pain and who was diagnosed with gastritis before, and when they came when they come, please, if they come for the second time, do ECG. And that patient actually who came with epigastric pain and was treated by gastritis was treated with gastritis apparently had inferior myocardial infarct and he was referred to the hospital immediately. So these are the things to keep in mind when you are prescribing. Sorry. Now I'm coming to the topic as such. Now, whatever I've said so far, you can forget. At least remember these 8 steps when you want to prescribe. So when a patient comes to see you, what do you do? Hidayah Arifin. So when a patient comes to see you, okay, what would you do, Hidayah Arifin? Want to try to answer? Hidayah? Hidayah Arifin? Malati is walking. Malati or Umi Tarani is walking. You want to try? Umi Tarani? You want to try Umi Tarani? Yumita Rani. Yumita Rani. What would you do when you want to select a drug? Say tomorrow a patient comes with a headache. How would you manage? How do you go about?
Doctor, can I try answer?
Yeah.
Okay,
You want
I'm
to sit down
Kumita
first?
here.
You want to...
Okay. I think Malati is back, so we let her answer. She's in the chat box, doctor.
Oh. Malati. Oh, okay. Ask further about headache, duration of the nature of headache. Yeah. And then, okay, you will take history, okay? That's what Malati is saying. Now, Mardia Sahara, after taking history, what would you do?
Hi, doctor. I would do physical examination after that.
Yeah, you will take the BP, pulse, and then what else would you do?
Do a neurological examination, visual acuity.
Yeah, that's good. So if say the patient, okay, once you have done, you make a diagnosis, isn't it? Okay.
Yes, doctor.
Yeah. So you will make a diagnosis. Okay. Now, after making a diagnosis, what happens? Anif Abdul Rahman. Anif Abdul Rahman, what would you do? You made a diagnosis with a patient with headache. So you'll proceed with Anif Abdul Rahman. You want to try? You make a diagnosis. What would you do next?
Investigation.
Yeah. So this patient with headache, what investigation would you do? Patient has 2 days of headache. So as a primary care doctor, you have to do point of care test. What point of care test would you do?
I'll do the basic investigation like FBC, renal profile,
Okay, good.
glucose monitoring.
Yeah. So again, when you are doing a point of care test, it has to be focused. Okay. When headache, you don't have to do most of it unless the patient has fever, isn't it? If the patient has fever, then you want to do a full blood count. You want to rule out what is the cause of fever. Is it dengue? Is it a viral infection? So you would do a glucose. You want to do okay. You want to rule out depending on the patient's age. Probably this patient got a non-communicable disease, diabetes, then you want to do. Unless otherwise you wouldn't do the whole set of routine investigation. That's the whole purpose of this GCFM. So you have to do a point of care test, cost effective test. Okay, some have done said visual acuity. Okay, now the visual acuity examine visual acuity is normal, but when you do, the next thing is you have to do field of vision. If this patient has, so this is where headaches are very important, even though it's a very simple, it could be a mental, he could be stressed at work, but when you have visual acuity, the patient may have, say, has a bitemporal hemianopia. What would you think of? Because these are all not common, but you need to keep in mind not all headaches are simple stressful headache or due to pregnancy, as someone has put that. Yes, pituitary adenoma. You need to rule out any pituitary tumor, okay? So these are real cases which I just mentioned. Patient came in with headache. Young person, 2025, went to 3, 4 clinics. Everyone thought he was came in for medical leave. So every time he goes there, he gets medical leave. So finally, he lands up with you. The employer says this guy has been taking MC, and so you have to really go through the history, see whether it's genuine or not. Majority probably have a simple headache or migraine or tension headache, but one red flag, Murtag has said, what other condition need to be ruled out? That's the red flag, okay? You should always think about whether this patient could have had a pituitary tumor. Okay, let me do a, a simple examination at the clinic, has bitemporal hemianopia. These are real cases which I had two patients who came with headache. One was a young guy in his 23, a chef. And another one was a 60-year-old director of a company. Both of them had visited 2, 3 clinics, came back, and then these are rare, but does happen. So you need to really look into the history. That's the first thing when you want to do a rational selection of a drug. You take the proper history, do a proper examination, do point of care tests which are necessary. Don't do the whole spectrum because we are trained doctors, primary care. So we do selective investigation probably at the clinic. You just want to rule out any viral infection. Okay, full blood count, fasting, random blood sugar to see whether it's high or low, and urine examination. This will be a basic investigation. If further investigation needed, then you refer the patient to the neurologist for CT scan or MRI. Okay, that's what happened. But then, as I said, when you make a diagnosis, at the end of the consultation, what happens? Can I just ask Kirtana? Kirtana, you want to try? I think Kirtana, did you answer something? Kirtana Gunasegarana. Okay. Once you make a diagnosis, what would you do for the same patient headache? Say it was a simple headache.
Hi, doctor.
Yep.
I'll come up with a management plan.
Yep. Good.
So I'll go for always prioritize non-pharmacological first.
Good.
So I'll try to counsel the patient and consult and find out what's the trigger actually, and try to be non-invasive as possible.
Okay, that's good. So are you going to prescribe or not?
For the beginning, maybe I'll prescribe painkiller first.
What painkiller would you prescribe?
Paracetamol.
Good. So
Yeah.
what I'm trying to say here is, at the end of each and every consultation, you will make a diagnosis, and based on the diagnosis, either you will prescribe, or you will refer the patient, or you will just counsel. Very simple, isn't it? Three things you do. So two things are very easy, lah. So referral and counseling is easy. So you don't have much problem. The first one is prescription. So you will prescribe. So you will prescribe only when you make a diagnosis. That's the point I'm trying to say is you need to make a proper diagnosis. Okay. If you miss the diagnosis, again, you are in problem. Now then, when you want to select a medicine for rational selection, you said you will give a paracetamol or NSAID. So again, depending on the pathophysiology, isn't it? If simple headache, you would say, okay, probably this is basically a paracetamol should be okay, should be quite sufficient. Even if it is a viral infection causing headache, you would just give paracetamol, start off with paracetamol. Even if it was a tension headache, you might just consider paracetamol. But if you think it was migraine, then probably the pathophysiology is different. You know that there's something else happening there. So, or if if the headache was due to temporal arthritis, when the headache is quite severe, then the pathophysiology is different. If say this patient was about 60 years old or 70 years old, comes with unilateral headache, um, you think unilateral headache, what are the possibilities? It's a very simple case of headache. What are the possibilities here? I will ask Ismail Abdullah. Ismail, you want to try? If the patient comes with unilateral headache, what are the things running in your mind? Ismail? Okay, I'll ask Chan Mei Yin.
Hi, sir. Hi.
This
Hi.
is this is
Hi,
Ismail
Ismail
or
here.
Chan?
Yes,
Yes, Ismail.
Ismail.
Okay,
Hi.
we are going back to the same simple case of headache. So now this is a 70 years old presents with unilateral headache, and he's saying, I've got a blurring of vision. What runs in your
Oh,
mind? What could be the pathophysiology in this elderly patient? What would you think?
what? Temporal arthritis? Oh,
Fantastic. So you'll think of temporal arthritis. So the point of care test will be
uh,
what investigation would you do if you think it's if this temporal arthritis to clinch the diagnosis? Anyone else can write
you
into
do a
the chat
CT
box?
scan?
No, not straight away, CD. Yes, someone has put the ESR. Yep, ESR. Not yet. ESR is the diagnosis. Okay. That will help in making a diagnosis of temporal arthritis. So you can see a simple case of headache. When you take a proper history and the patient says unilateral and my vision is blurred, the entire headache thing changes. So here, if temporal arthritis, the diagnosis you mean the point of care test indicated is ESR, and you need to do a biopsy of the temporal artery, not CT scan. Now you see how a simple case of headache, a lot of things in rational selection. What would be the treatment for the second case? Now, let me ask, what would you do? Chan Mi Yin. Say temporal arthritis ready, and you have done ESR, you have confirmed the diagnosis, is most likely ESR is 90 to 100. So what would you do, Chan Mei Yin?
Hi, doctor.
Yep.
I will refer to neurologist.
Yeah, fantastic. So you see there's so many difference between the first simple headache, the second simple headache, not simple, but a serious headache. So the pathophysiology changes. So depending on the pathophysiology, you will specify the therapeutic objective. You need to have a specific therapeutic objective. Now, say the patient you want to refer is very far to the neurologist. So, what specific therapeutic agent would be good for this patient? Anyone can put into the chat box. What would be the
High-dose corticosteroid.
Yes, steroid. So steroid prednisolone is the drug of choice for temporal arthritis. So what the point I'm trying to say is, even though it is a simple head, it could be a case of headache with proper history, proper examination, proper point of care test, your therapeutic agent changes. Now you are selected appropriate therapeutic agent for this patient and you started the treatment. What are you going to tell? You're going to tell the patient about the diagnosis. Very important. You're going to tell diagnosis is temporal arthritis. And then you have to tell, I'm going to give steroid. The moment you say steroid, the patient will say, Doctor, I'm just having headache. Why are you giving me a steroid? Then you explain to them, this is very important. Temporal arthritis can cause blindness. I'm referring you to the specialist. Meanwhile, please take this medication I'm going to prescribe. But before I prescribe, I want to ask, do you have high blood pressure? Are you taking any other medication? Do you have gastritis? Tell them about the side effect. And then you need to monitor the patient, okay? You need to, here you have referred the patient, but in any other case, you're giving steroid, for example, if it was asthma patient, you're giving acute asthma, you give steroid, ask the patient to come back and see you in a specific time. So it depends on the duration. So you need, and then you need to monitor the treatment and if possible, reduce prescription error. Just like the doctor who said, I will give non-pharmacological treatment. For some patients with headache, you don't have to have any head treatment at all. You just talk to them and get the trust of the patient, and then they will tell you, Doctor, I'm having a headache because my spouse, I'm having a problem, I'm having a marital problem, I'm having problem with my child, having problem with my workplace. So they just want to come and talk to you, and then you counsel them, and then probably look at the mental health. Probably they just need a few sessions of counseling. You don't need to give any medication at all. So these are the few things when you prescribe, when you want to prescribe medication. So remember this 8 steps, which you're going to use it for the next case. First, you determine the patient's problem and make a diagnosis. Consider what is the pathophysiology. Specify the therapeutic objective. Select appropriate drug. Start the treatment. Give information, instruction, and warning. Monitor the patient and ask them to come back. Okay, monitor the patient means it's basically follow up. Any patient you see, give follow up. Am I okay? Am I going too fast? Too slow?
Okay.
Right. Now, when you want to select a medication, again, determine the preference, whether it's a generic or a brand one. A generic or trade name of drugs must be written in full in patient's medical record. Okay, always this legal document, whenever you're prescribing, write it. But it doesn't matter brand or generic. Because again, if it's a private patient, you have to tell them the cost. Nowadays, even government, they're procuring medication from the locally. That means mostly a local medication rather than imported one because it saves a lot of medicine, a lot of cost. So this is our new building. It's a very beautiful building. Okay, those who have not, just have a walk inside and look into the facilities. Now, you're going to apply the same 8 things, and I'm going to ask question. This is a 35-year-old man presents with severe sudden onset of first toe pain and swelling. This is the first episode, no trauma. He's on a thiazide 25 milligram daily. Temperature is 38 and blood pressure is 150/100. Now, I'm going to ask Shomana Nair. Shomana? You want to try? Okay, this is the thing. What are you going to do tomorrow? This patient comes to see you. Shomana, are you there?
Yes.
Okay, this patient comes to you tomorrow, and you can ask me the questions. I can tell you because you're going to take history to you. You have to come to a diagnosis, isn't it? You're going to take the history. The history is already there. It's the first episode. Sudden onset, no trauma. Any other history you want to take?
How long has he been having the toe pain?
It's already written there. Sudden onset of first right toe pain. This is the first episode.
Does the patient has any non-medical illness?
He's on hypertensive. The blood pressure is high. He's on thiazide 25 milligram daily.
Oh,
No trauma. Any other history you would want to ask the patient? Because
Any allergic to medications?
no.
Or allergic? Um,
So already they are already putting the diagnosis in the chat box already. Okay. Okay. Well done. So what do you think the diagnosis?
it could be gout.
Yeah. So if you're thinking gout, what questions would you ask the patient? After the first set, you will ask about the family history, isn't it? Would you want to
Yes,
ask whether your any family history of gout in the family?
yes.
Would you want to
Any family.
ask? Yes. And then would you want to ask about the food intake? Because you know that sometimes when the patient has taken too much of high purine diet the previous day would cause gout, would aggravate a gout. Would you want to ask that?
Yes, and if you got any blood investigation taken before.
Yes, whether the uric acid level. So this is how you approach a patient. Now, what is okay? Now I'll just go to the other person, Nurul Huda. Now you already taken the history. You examine the toe is warm. You already thinking of three differential diagnoses. What are the three differential diagnoses? Because usually you always need to have a differential diagnosis. Nurul, what are the three differential diagnoses you want to think about in this patient?
Hi, doctor.
What three, just name three differential diagnoses running in your mind at this point of time. One what is already gout ready lah. Patient already said gout.
My differential diagnosis would be septic arthritis, trauma,
Mm-hmm.
uh,
You can see the slide already.
yeah, acute cellulitis.
Okay. So these are the three things there. So most likely diagnosis you are thinking is, Devika, what is the most likely diagnosis in this patient? Devi,
Yes,
Devika.
doctor. Yes,
Yeah.
sorry,
What is
sir,
the
can you
most
repeat the question?
what is the most likely diagnosis in this patient? Because you need to define the patient's
Yes, my diagnosis will be acute gouty arthritis secondary to the BP medication, which is the typhoid.
typhoid. So what investigations would you do?
Uric acid, baseline RP, renal profile,
Okay.
baseline renal
Okay.
profile,
Yeah.
uric acid.
Urine profile usually has uric acid. Okay, right. Basically, what I'm trying to say is the point of care test is uric acid. You will do a renal profile, see assess the renal function. But during acute gouty arthritis, the uric acid may not be the acute, not tell the true level. So you need to repeat it later and see. So if there was a septic arthritis, what investigation how would you know it's a septic arthritis? Let me ask Izzatul Iwa. If there was septic arthritis, what would you do? Izzatul Iwa. I cannot hear. If it is septic arthritis, what would you do, Dr. Izzatul Ewa Binti Esa? Izzatul, are you there? I can't hear you. Did you say something?
Hello, doctor. Hello, doctor.
Yeah, Izzatul. If it was a septic arthritis, what would you do?
Okay. First of all, I will do proper examination and investigations.
Okay.
Okay. And then take FBC to look for the total white cell, any in the infection screening. And then I will do I will refer to ortho as well for the septic arthritis.
Yep. Fantastic. Good. So the point here is, so the most likely diagnosis is acute gouty arthritis because it's acute onset. Septic arthritis, the patient would have encountered pain for a couple of days associated with fever, all those things. The diagnosis for septic arthritis is basically you need to aspirate the joint. When you aspirate, you can see pus. And if you aspirate, and you can even check for gouty arthritis, the crystals. So for the diagnosis of septic arthritis, what the specialist will do is, of course, I'm not usually in case of a knee or anything, they will aspirate and see whether there's any pus or not. So that clinches the diagnosis. In this case, the aspiration is negative, so it's not septic arthritis. But if it is septic arthritis, the point noted is you will refer the patient to the specialist, unlike gouty arthritis. Gouty arthritis you manage in primary care, while acute septic arthritis you refer to the orthopedic surgeon. So this is where the referrals comes in. Now, what is the pathophysiology involved in gouty arthritis? I'm not going to go into detail. There's increased production of uric acid or decreased excretion of uric acid. Basically, the uric acid level is high and goes and sits into the joint and then causes acute gouty arthritis. That's yellow number 2. You can even have asymptomatic hyperuricemia. You do a blood test, the uric acid level is high, but they're asymptomatic. Then there's acute gouty arthritis, and then you treat the patient, and in between the patient is pain-free, and then there's advanced gout where patient comes and presents with gouty arthritis as well as tophi. So now we have managed to think of the pathophysiology. So now you're going to choose a specific therapeutic agent. Now I'm going to ask Dr. Lee Xiu Lin. Dr. Lee Xiu Lin, this patient comes to your practice and you have taken the history, have examined uric acid high, and what are you going to do? How are you going to manage this patient?
First, for the management, again, non-pharmacological and also pharmacological.
Yep.
So for non-pharmacological, we need to have a proper counseling to avoid the high purine diet, cut down alcohol, and all the risk factors. For pharmacological, would be NSAIDs, or if NSAIDs is not manageable, add on colchicine and also steroid. This one is for acute flare. For long-term management, need to depends on the risk factor, whether this is the first flare, depends on the level, whether it's very high, then we might need to consider allopurinol.
Okay, thank you. That's good. That's fantastic. So this is how, when a patient comes with a gout, you need to tell them you have to have a 2 management line. One is pharmacological, non-pharmacological. Here, the patient comes with acute pain. So you need to ease the pain. So ease the pain is 1, and at the same time, reduce the uric acid level is the 2nd. So the ease the pain, you already said you will give NSAID, and these are the NSAIDs you can give: indomethacin, naproxen, celecoxib. You have to use full therapeutic dose until symptoms subside, usually for 5 to 7 days. Always remember, ask them, do you have renal impairment? Do you have peptic ulcer? You have heart failure? Because when you're going to use NSAID and celecoxib, it can aggravate the heart failure. Then you add in colchicine. Okay, colchicine is 1.2 milligram initially, followed by 0.6 milligram 1 hour later, and then 0.6 milligram once or twice daily. Again, used in care with renal hepatic impairment. If the patient is sensitive to allergic to NSAID, then you combine colchicine with corticosteroid. There's prednisolone, or you can give intra-articular triamcinolone, and consider if NSAID and colchicine are contraindicated. So you don't give all the 3. Either you can give NSAID and colchicine, or colchicine and corticosteroids. This is for acute pain. Next is for uric acid. During acute attack, you don't know whether it's gout or not, so you will not start him on xanthine oxidase inhibitors like allopurinol, or if they are sensitive to allopurinol, you will start them on febuxostat. So later part, do not start during acute attack, but if the patient is already have a gout, then you can continue with allopurinol. So what is the dose of allopurinol? 100 milligram per day, okay, 50 milligram per day in CKD. So it has to be reduced and titrate to target the uric acid level is less than 6 milligram per deciliter. If the patient is allergic to allopurinol, then you start them on febuxostat. So then the second line uricosuric agent is probenecid. Okay, not so commonly used, but we leave it to the rheumatologist. And these are the newer medication called pegloticase, reserved for refractive gout or patients intolerant to other uric acid lowering drug. And prophylaxis during the therapy, low dose colchicine or NSAID to prevent flares during the first 3 to 6 months. But you can just give them, don't ask them to take every day long, because NSAID can cause a lot of side effects. Of course, you have to educate the patient what is gout about, why is it coming, because if the patient it should be patient-centered, as I mentioned, you need to tell them about gout and then what precipitates. Tell them there's no management without talking about diet. Avoid high purine diets such as red meat, shellfish, organs, meats. Limit alcohol intake, especially beer and spirits, as mentioned by the doctor. Reduce consumption of sugar-sweetened beverages and fructose. Encourage low-fat dairy products, vegetables, and hydration. Very important is weight management. Ask them to lose weight to reduce uric acid and promote regular moderate physical exercise, because during acute attack, they may not be able to exercise. You also need to give a side effect of all the medications you're going to give. Colchicine, one of the side effects is diarrhea. You have to tell them, okay? That's a common. So the seventh feature of rational prescription is monitor. So you have to monitor the patient. Once you have started treatment, ask them to come back in about 1 month time for therapy to lower the serum uric acid level. Because during acute attack, you're not starting him on uric acid lowering therapy. So you ask them to come back after about a month. But you have to also give a patient to come back immediately if he has any side effect to the medications you are treatment. Like if you start on an NSAIDs and then you say there's black stool, you have to come back, melanic stool. Okay. Then if uric acid lowering therapy is begun, patient should be seen within 2 weeks. So this is 2 weeks to ensure that no untoward toxicity, because uric acid, allopurinol, a lot of patients develop Stevens-Johnson syndrome. So you have to be very careful, tell them these are the side effects. And then every 1 to 2 months. I mean, first, once you start, 2 weeks time, ask the patient to come back. And then every 1 month, you see them, adjust so that the uric level is at 5 to 6. Follow the patient for 6 to 12 months to monitor the serum uric acid and the renal function. So when would you refer the patient? If the patient's eGFR is less than 20 ml, then I think you do not start him on, you can just start them on prednisolone or tramadol and then refer them to rheumatologist. That is the best thing. Okay. If the serum uric acid target is not achieved, then again you have to refer the patient to the rheumatologist. Or if the patient has comorbidities, heart failure, renal impairment, you are a bit not so sure of management, then you refer to the patient. Patient, you've got a CKD, refer to the both rheumatologist as well as nephrologist. Now we go to prescription in elderly. So this is a 72-year-old man with history of congestive heart failure, hypertension, complaints of persistent arthritic pain in her knee. Her current medications are furosemide, potassium, lisinopril, metoprolol, calcium, T supplement, 800 units daily. After examination for arthritic pain, you diagnose osteoarthritis of the right knee and prescribe diclofenac sodium for pain and inflammation. So now again, you have to be quite careful. Okay, this is the patient. A lot of time, elderly patient come with osteoarthritis. They come with genuvalgum. So you have to be careful when you're prescribing sodium, any NSAID who has in a patient who has congestive heart failure, as well as, and also COX-2 inhibitor. So you have to be careful because it can aggravate and worsen the heart failure. So start off with paracetamol for these patients. So you always remember that prescribing NSAID has a cardiovascular risk, which include increase in blood pressure, aggravation of the heart failure. Next is gastrointestinal risk. I'm sure you all know, but you have to remind yourself so when you are prescribing that these are the side effects. Should I really prescribe any medication? So paracetamol is quite safe. So they have a gastrointestinal risk factors which include peptic ulcers. So you need to be quite careful. And then think about renal risk. And also this patient has multiple morbidities. So there is polypharmacy and interaction. So remember, diclofenac sodium can interact with furosemide, potentially reducing the diuretic effect as well as can affect the kidney. So what would you do? You will stop and say that and minimize the potential risk. So you will prescribe acetaminophen, averaging to 1 dose daily. Okay, this you can increase it twice a daily. And then if there's a breakthrough pain, you just give low dose tramadol. Okay, that's an opioid. Then the next option is we just give a patch or gel. Okay, gel, anti-inflammatory gel or topical gel or a patch. So that will help in osteoarthritis. Worst case scenario, refer to the orthopedic and they might just give him hyaluronic injection. And later, if it is the activity of daily living is impaired or restricted, then they might recommend knee replacement. So what else would you do? Non-pharmacological treatment. Any patient, just tell about non-pharmacological. They'll be happy. They will be happy not taking medicine, but again, tell them about lifestyle changes such as physical therapy exercise program to strengthen the muscles around the joint. Usually non-weight bearing exercise will be good for osteoarthritis. Walking aids and braces to reduce joint strain. If they're overweight, ask them to reduce weight and tell them about the side effect about when you're prescribing some medication like melena, swelling, and shortness of breath. So these are indicating of GIT side effect as well as cardiovascular side effect. So did you did the morning session you all had about wrong prescription by the lawyer? Did you all have a session on wrong prescription? Shall I go?
Yes,
Or
doctor.
so you all had a okay, I'll just go very fast about this patient.
Can,
73-year-old, yeah. 73-year-old man comes for a review of blood test which shows renal impairment, has type 2 diabetes mellitus, hypertension, and dyslipidemia. It's your last patient and you prescribe his usual medicine for hypertension, diabetes, and dyslipidemia. The next day, you notice the medication dosage dispensed are incorrect because in a hurry. What would you do?
Call the patient and arrange for the follow-up and readjust the medications, doctor.
Yeah, so that's correct. So what you'll do is you will call the patient immediately, okay? Contact the patient as soon as possible. Assess the patient's condition and take necessary actions to maintain stability. Arrange for redispensing the correct medication. You tell them, sorry, medications, there's some changes to need to be made in the medication because of this, because your blood test report came, it shows a little bit of renal impairment, so I need to make the change. So incorporating computerized alert system, implements tools for guiding medication, prescribing, means stop, screening tool for older persons and prescription, and also start screening tool to alert to the right treatment. So you need to have this in your electronic medical record and prescription. So this will help to prevent wrong prescription. So immediately what to do next is the error must be reported immediately to the person in charge, okay, to your FMS. And the clinician in charge of the patient's care according to the standard procedure. Each KK will have their own procedure, but if you're a private, you need to have a SOP. That means you call the patient, inform your superior, or you inform your staff, and then you just find out why did this happen. Is it because of you were in a hurry? Is it because you missed the diagnosis, or is it because you didn't look? Why? How could it be prevented and eliminated? So you need to do a incident report form, either online or manually, document the patient's record, establish, implement error prevention strategies, and focus on systems design, and also contact your indemnity indemnity manager, okay, the lawyer, and tell them this happened, because you don't know the patient's family might just send you a legal notice later part. So this all happening actually. So this one I already told you about the misdiagnosed patient coming with epigastric. This is a real case scenario where a patient comes with epigastric pain, you treat them for gastritis and you misdiagnosis. Again, you can be sued, okay? So always remember, misdiagnosis again can lead to wrong prescription, and that can cause a lot of, there is a legal implication. So what is the importance of difference? That's why you need to have a differential diagnosis when a patient comes. Could it be this? Could it be that? And always tell, okay, if you're not getting better, please come back and see me in 24 hours, especially epigastric pain and elderly patient. Young patient is different, but elderly patient, tell them if you're not getting better, you come back. This is my phone number. This is the clinic number, or you just go to the emergency department of the hospital, nearest hospital. Always remember about epigastric myocardial infarct. So what is the learning point? Always perform a comprehensive assessment, especially in patients with multiple risk factors for serious conditions not to be missed. And early cardiac evaluation is also important. Okay. Now, just to a summary of what happened. What happens if you misdiagnose a patient? Contact the concerned family, form an inquiry committee, acknowledge that something had gone wrong either in response to their inquiry or initiated by the practice, offer an expression of regret or apology if warranted, but do not admit liability. Explain what happened. Just tell them actually what happened, and explain what are the steps you have taken that this mistake will not be repeated. Communicate openly and honestly. Keep a record of any discussion and the apologies in the patient's card. Record any incidents in the patient's record and seek medical defense organization. That means I already said contact your indemnity company for advice. This is our building at night. It's beautiful, isn't it? Anyone have an idea how much we spent for this building?
No idea, doctor.
Are you all interested to know because you are a member of academy?
How much was it, doctor?
Yes, doctor.
It all cost about 85 million, the land and the building.
Mm.
1/3 is our expenses now. 2/3 belongs to Academy of Medicine. So 1/3 of the 85 million we spend. Okay? 12 million, 30 million. Wow. So yep, it's 85 million. Nearly, sorry, it's about 75, around 75 million. Okay, someone is playing with the kid. That's good. A family physician, but now you can mute and you play with the child. Polypharmacy. Again, this is very common in elderly patients. Okay, this is a patient, 84-year-old man who has congestive heart failure, hypertension, arthritis, hyperlipidemia, and a history of myocardial infarct 8 and 2 years previously. He requires assistance with his activities of daily living and remains ambulatory with a cane. His usual medications are metoprolol, aspirin, omeprazole, lisinopril, furosemide, potassium chloride, atorvastatin, acetaminophen, tramadol, multivitamin. Well, this is not these are some of the common conditions you all see, isn't it? I'm sure you're all not surprised by this number of medicines in a patient with so many morbidity. Now, this is where you are going to do the prescription. So I'm going to ask, say, Sui Ya Wen. What are you going to do to this patient? these are the results of this. His blood pressure is okay, temperature is normal, heart rate is okay, respiratory is okay, height, weight is there. There are few lung creases. There's no edema and unremarkable. So now what are you going to do? You're going to stopwise approach. How are you going to approach this patient? Decide a drug that is indicated, choose the best drug, determine the dose, monitor for effectiveness and toxicity, and educate. So you have to prescribe, you have to continue with the medication. So this patient has been in this medicine for about 6 months and then comes to see you, Dr. Shui Ya Wen. What are you going to do? How are you going to do the periodic review? And what are the medication you're going to discontinue? And what are the non-pharmacological alternative? And what are the safer alternative? We're going to apply stop and start tools now, okay? So when you have this stop and start, they will tell you if the patient is on beta blocker, patient can have bradycardia or hypotension. So CNS and psychotropic long-term benzodiazepines and or anticholinergics, patient at risk of falls. And gastrointestinal proton pump inhibitors at full dose for more than 8 weeks without an indication. So that tool will alert you, okay, stop tool. That's a screening tool for older person. So you need to have it. And then the start tool, you have to have it also will alert you of the thing. Now coming to the patient, Sui Ya Wen, you are still not answering my question.
Yes, doctor. I'm Sui.
Yeah, Sui, you want to try? This patient, which 82-year-old man, is on metoprolol, aspirin, omeprazole, lisinopril, furosemide. The blood pressure I told you is quite. The pressure is 112 by 62, and he's on metoprolol, lisinopril, furosemide. Would you want to continue?
I think I will reduce the metoprolol, the dose of the metoprolol ER to maybe 25 first. Or actually we can try to, but because the patient has heart failure, so beta blocker is good for the heart. Yeah, so I would reduce to the lowest dose, and then the furosemide maybe I will change to as needed PRN, 20 maybe no need all every day, no need to take it every day to reduce the risk of the AKI and worsening the kidney. Yeah.
So you will reduce the dose of metoprolol to half. Okay, dose reduction should be considered. And then aspirin is 3 to 5 is quite high. So you want to also reduce the dose of aspirin. Okay.
Yes.
And then omeprazole may not be necessary because once you reduce the dose, probably he may not require. Lisinopril, ACE inhibitors should be part of the treatment plan for a patient with congestion. You will continue with it. Furosemide, as I said, as you said, you will reduce it or discontinue. Now, potassium chloride, you will monitor the potassium chloride because the patient is on furosemide for long term, and you will adjust the dose. Atorvastatin, 82 years old. So probably you want to stop it. You might want to stop because there's limited evidence base for use of statins in patients older than 80 years old. So you might consider stopping the atorvastatin. Acetaminophen 650, probably you can tell them because he's got some knee pain and he's using aid, he can continue with low dose. Tramadol as needed. So you can remove tramadol because you don't have to prescribe him. Okay, you can tell him to stop it because I'm sure the patient will have the medication which was prescribed every month. He will have a big load. Multivitamin, you can continue with the multivitamin. So remember, when a patient comes with an elderly patient with multiple comorbidity and has polypharmacy, start deep prescribing and review the medicine. You see what was the last time the patient's medication was reviewed, and then you do the necessary action. Prescribing in children, minimize the dose. Okay, children also, again, you have to be careful. Minimize the dosing frequency where appropriate. Means like if the patient needs antibiotic, probably azithromycin once a day for 3 days is better than Cefalaxin 3 times for a week. And then also avoid medicine that are known to be less palatable. And nowadays, most of the syrups are a bit sweet, so that's good. And you can use alternative route of administration for children who can't tolerate orally, rectal than oral, but again, rectal a bit erratic, and different ways to alter the medicine taste, aftertaste, and mouthfeel, which may help to improve. Just a little slide for those those who are seeing a lot of prescription. Usually, what you can do is try cold treats like an ice cream or ice block to numb the taste bud before you give medication. Okay, the child, like, you just give ice cream. Of course, you see whether it is indicated or not. Or you can mix with fatty food like peanut butter or chocolate to coat the taste bud before you give the medicine. Or you have the child's favorite drink ready to follow with the medicine. You tell them, okay, you like Rabina, okay, I'm going to give Rabina. Then give a sip of Rabina, give the medicine, and give the Rabina. So these are alternate general ways. Now, the next one is what you can do is you can cut the tablet in half before swallowing. Sometimes slightly bigger children, you can cut it or make it a powder, mix it with honey and give. You can, honey or yogurt or custard you can give. Or you can crush the table or the capsule and mix it with some sweet drink. And then what you can do is use a syringe and aiming towards the back of the mouth against the inner cheek. This is very common. The nurses, you can see, they will just using the syringe, hit the cheek rather than the taste bud, because the tongue has a lot of taste bud. And when it hits the tongue, then the child will feel the bitter taste and not take. So just hit the cheek. The next is pour the medicine into a small cup and drinking with a straw. You can even mix with some sweet drinks. Okay, this is the ways to give for children. So this is our new building, 75 million building at night. And this is the mosque behind. This is the lake. It's quite beautiful. Now we are laying the solar panels at the top of our building. Now we are coming to a prescription thing. I'll just go through very fast because I'm sure you all know about this. A prescription is a written, verbal, or electronic order to a pharmacist for a specific medication for a particular patient. So you are responsible. You are clinically and legally responsible for your actions if you prescribe a drug. You're asked to prescribe the drug, it is the person who signs the prescription who is responsible. That means even if your consultant are asking to write, you are writing it on the card, you are legally responsible. So be careful. Nowadays, electronic prescription are part of the broader digital healthcare. I think most of the KK have digital electronic medical record and then digital prescription. While paper prescription are still available in some clinics, you need the electronic one is better, okay? And because it prevents the illegible handwriting. As I mentioned earlier, consider religious, cultural, and personal belief that may affect the acceptance of medicine, okay? Keep drug regimes very simple and review them regularly. Combination treatments will improve compliance, especially for hypertension. You have 2-in-1, 3-in-1, antihypertensive together. So that will help in compliance and adherence. So remember, prescribed medications that you are competent to prescribe. Just remember, keep few medicines in your mind and you know the side effect. Just prescribe that. Do not just prescribe what the drug representative is telling you. Prescribe medicines if they are really necessary. Prescribe only if the benefit of the medication outweighs the risk. Always discuss with the patient and always discuss the side effect and tolerability with the patient and the mother. So any prescription, this is a standard prescription, will have a heading, the body and closing, which I will go very fast. These are sample prescription. This is a sample prescription, heading, the body, the signature. And these are the dosage, list of dangerous drugs and list of the abbreviations. You make sure you write unit because sometimes there can be error. IU, please write IU properly because it can mean IV. So be careful in the prescription. Okay, these are some of the common abbreviations. So how many of you all are dispensing psychotropic drugs? Hello? Are you all able to hear me?
Yes, doctor.
Yeah. How many of you all having prescribed psychotropic drugs? You know how to? Can someone tell me how do you dispense the psychotropic medicine? How do you dispose the expired psychotropic drugs? Selvam, you want to try? How do you dispose psychotropic drugs?
Sorry, Prof. I am under clinic kesihatan setting. So usually this medication, even though it's diazepam, list B, sometimes we are not allowed to order that without the specialist
FMS.
approval. Yes. And for my this one lah, for my clinic kesihatan. And then the disposable part, sincerely, I have no idea because that one the pharmacy takes care of it.
Okay, right. That's okay. That's why we are having this session. Okay.
Yeah.
Any private practitioner? Because GPs, any GPs out there? I'm sure the GP can answer. Any GP out there? Any GP out there? Oh, there's no GP at all.
Hello, boss.
Any GP?
Sir?
Private
Hi, doctor.
practitioner?
Hi, doctor.
Yeah. How would you dispose the expired psychotropic drug? Because you need to know. The enforcement agents will come and ask you.
Yes, yes, doctor. So, I don't usually give any psychotropic drugs, but I keep the most important ones in the clinic, like adrenaline. So, these are the important drugs to be kept in the clinic. So, this one, what I'll do nearby our clinic, there is a big pharmacy and AA pharmacy. So, usually, if it's expired, I'll just give it to them, doctor.
Huh? You'll give to the or the adrenaline, no, but how about the diazepam, alprazolam?
Oh, I don't keep them, doctor.
Right. But anyway, even if you don't keep, so this is how for those people, whenever under the Poisons Act 1952 of Malaysia amended in 1989, all clinics should maintain a prescription book and prescription register which should contain the date dispensed. Of course, the KKM, the pharmacists will do, while the GPs, please maintain a prescription book and register. It should have the date, serial number, name of the medicine, patient's detail, name and address, and stock in possession. Okay, now, and the labeling of poisonous of psychotropic substances, again, the GPs there, under the Act, all clinics should maintain a prescription book and a register which should contain the name of the supplier, okay, name and address of the supplier or seller, patient or purchaser, name of medicine, date of delivery. So you need to maintain two books, prescription book and prescription register, and also the supplier, especially for psychotropic drugs. You need to maintain two books. I'm talking to the private practitioner, but again, doctors who are in the KKM, even though you don't know, this question will be asked in your exams. Okay, so now you should know. So in case they ask you, you need to know. Especially this question will be asked in part 2 of advanced training in family medicine. So this is a format of prescription book. Those practitioners who do not have, you need to have a book. It's not a computer book. You need to have a hard copy of the medications supplied, especially the sedatives and antipsychotic. These are the format of prescription. So when you are prescribing, you need to write the who received, the serial number, the name and address of the patient, identity card, quantity supply, and the stock in possession was the balance. Now, all this medicine should be stored in a cupboard or a drawer under lock and key and reserved solely for storage of poisons. Now, coming to disposal of the psychotropic drug medication, remember disposal of psychotropic medicine must be done in the presence and under the instruction of drug enforcement officer. If you have, do not go and give it to the AA pharmacy or big pharmacy. You have to keep it. You must inform the drug enforcement agent officer that you have this medicine. You have stored and it's expired. I didn't complete the prescription, so I have a balance of 20 medicine, and in the presence of the drug enforcement officer, the date and quantity of psychotropic substance disposed of must be entered into a register and shall be acknowledged by the drug enforcement officer, and it has to be disposed in front of the uh, enforcement agent, enforcement officer from the Ministry of Health. So remember this: you cannot just throw into the dustbin, or can pass over to the if of course the pharmacist won't take the Valium or alprazolam. They will say, no, doctor, you won't come. So coming back to the point selection, so remember, define the patient's problem and make a diagnosis, consider pathophysiology involved, specify the therapeutic objective, select the appropriate drug therapy, start treatment, give information, monitor treatment, and reduce prescription error. So this will be the last few slides, prescribing in pregnancy. So remember, timing of exposure, pre-embryonic phase from conception to day 17 post-conception, all or nothing phenomena. That means during this period, insult could lead to death, miscarriage, resorption, or intact survival. So be careful during this period because anything can happen. Nothing can happen or something can happen. Then you have this embryonic phase, that is day 18 to 55 days, day 55. That means say roughly 2 months. Okay, third, from 18 to 55 days, crucial period. And this is the period of organogenesis. The earlier the insult, the greater the effect. Insult could lead to congenital malformation. So be careful. This is a very crucial period. So as far as possible, you have to ask yourself, does this patient need any medicine? If not, just conservative management, because this is the time the development is taking place and any insult can lead to malformation. Then the fetal phase, that means after 2 months to term, impact depends on the placental transfer. No association with structural malformation, but we cannot say. Okay, the newer medicine can cause a lot of changes. So remember, first 2 months, you have to be very careful, okay? So evidence of medication risk during pregnancy and lactation remains relatively limited to barriers in clinical research. We don't do research on pregnant ladies, so there's ethical issue there. Some women would have taken some medication unaware they were pregnant, and it's difficult to identify if the medication prescribed later contributed to the fetal abnormality. We are not sure because, again, patient would have taken and then comes to see you, you give medicine, patient has develops a fetal abnormality, might come back and tell you, doctor, it was your medicine that caused fetal abnormality. So always record what medicine you have given and ensure it's evidence-based and doesn't have any toxicity to the baby. So of course you all know what is this, isn't it? Fecomalia, thalidomide. In 1950s, a German company came out with thalidomide and they said this is the best new drug for vomiting, nausea and vomiting. And thousands and thousands of medicines, millions of medication were prescribed all over the world. And then children were born with abnormality. Initially, they did not know, tie up with thalidomide. So that was the greatest tragedy in medicine, okay? A lot of children were affected. Even now, you can see some of the children without limbs and legs and arms, okay? This is quite sad. So always remember the basic principles in pregnancy. Medication should only be prescribed for clear indication when the benefit outweighs the risk. Medication should be used in the smallest effective dose for the shortest period. If possible, try to avoid medication in the first trimester. Only use medication that have been proven to be safe in pregnancy. If unsure, contact the pharmacist or the specialist for clarification. So this is for pregnancy. Now, just a simple case scenario which we encounter every day. Pregnant women comes for antenatal and then says, doctor, I'm going overseas. Can I have fever, flu, cough, and antidiarrheal medicine? So what are you going to do? So always remember which month is See, this 22 weeks. So as I mentioned, First 2 months is the period where there can be insult to the baby. So now, when you're talking about cough and cold during pregnancy, of course, you will always tell about non-pharmacological therapy. You say, okay, cough and cold is viral infection. You don't have to take any medicine. Do steam inhalation. Drink warm water. I think that should be all right. And then say, doctor, I'm going overseas in case it gets worse. Then he probably might say, okay, I'll give you this medicine. This has been there for many years and we have given it for many. But again, the side effect of this medicine is you feel a bit drowsy. And if you're traveling, again, that will be a side effect. Just think about it. Just take at night. And it is safe in the second trimester, okay? Chlorpheniramine. Cough suppressant, dry cough, you can give dextromethorphan or well, for phlegm, you can give guaifenesin. These are quite safe during pregnancy. So how about second generation, cetirizine and loratadine? Can we give? Well, they also can be given with fewer sedative effect. They are quite okay because the first generation has a lot of sedative effect. This one doesn't have, so you can prescribe once a day. And for severe allergies or allergic rhinitis, you can give loratadine or cetirizine can be safely used in the first trimester when the symptoms significantly impact quality of life. Okay, as I mentioned, as far as possible, you avoid medication, or if it really affects the pregnant mother, then you can tell them for a short course after 8 weeks, right? As the first trimester is already 16 weeks already. First trimester generally considered safe, though limited data exists for the. I mean, what I mentioned is first trimester. When I say first trimester, avoid the first 55 days, okay? First 55 days, that's where a lot of organogenesis is taking place. If possible, try to avoid, but if really needed, then you can give lah. So these are grade B, all these are category. Chlorpheniramine, diphenhydramine, loratadine, cetirizine, first generation, second generation, and these are second generation. Okay, chlorpheniramine most studies generally considered safe in all trimesters. Diphenhydramine, safe but high doses near term may cause uterine contraction. So remember diphenhydramine. Loratadine, good for allergic rhinitis, and cetirizine, safe, minimal sedation, preferred second generation. Now, for nausea and vomiting, I'm sure a lot of you all have done ONG and see a lot of pregnant ladies. The first line is vitamin B12 with doxylamine. B12 with doxylamine is quite safe, FDA approved for emesis gravidarum. So other medication which you can give are metoclopramide, promethazine, pyridoxine. Now, for pain? Any medicine is not safe in pregnancy. However, paracetamol is much better than other medication. Try to avoid NSAIDs and aspirin during pregnancy as far as possible. So antibiotics which are contraindicated are aminoglycoside, chlorophenicol, quinolone, sulfonamide, tetracycline. These all are no. Okay, safe antibiotics, if you want to give for UTI, chest infection, you can consider amoxicillin, cefalexin, and erythromycin. So absolute contraindication, antifungal. Do not give crisaphulvine, ketoconazole, itraconazole, fluconazole, terbinafine during pregnancy for fungus. You can just give topical, okay? Like if they have vaginal candidiasis, give clotrimazole. This is quite safe. Anti-inflammatory, again, COX-2 inhibitors, NSAIDs, try to avoid. Anti-helminthic like mepetrazole, ACE inhibitors, angiotensin, spironolactone, and vitamin A analogs, try to avoid their absolute contraindication in pregnancy. Vaccine, inactivated influenza vaccine can be given, okay, during pregnancy, but any live vaccine like rubella, varicella, polio, hepatitis, pneumococcal HPV should not be given during pregnancy. So as I said, live vaccines cannot be given, but to a child, mother brings a 12-year-old child for vaccination. The child has completed all except for MMR and varicella. Both are live vaccine. Can you give both at the same time? Yes. For children, this one, different topic. This is for a child, 12-month-old child. Don't mix up with the live vaccine of pregnancy. For pregnant women, live vaccines cannot be given. For a child, live vaccine can be given on the same day. If they are not given on the same day, they should be separated by 4-week interval because immune response to one of the vaccine might be impaired. This is the last slide. Good referral practice. I mean, for referral, I've already discussed with you what are the conditions to be referred. In case of emergency, okay, acute myocardial infarct, perforated duodenal ulcer, ectopic pregnancy, ocular emergencies like blunt injury, herpes zoster, ophthalmicus, okay, ENT, croup. All these things have to be referred to respective specialists. Some people you want to refer for investigation, as I mentioned, you want to send for OGDS, you want to send for CT scan for that patient, MRI for that patient with pituitary adenoma. So you want to send them for investigation. You're not sure the diagnosis you want to refer. Then you want the patient needs specialist treatment. You have treated the patient for GERD. Patient is not responding. So you refer them for specialist treatment. Sometimes you might want to refer for a second opinion. And of course, demanding patient says, Doctor, I don't trust you. Can you refer? So better refer because you don't want to be in trouble with that patient and the patient can spoil your day. Reassurance. You tell the patient, okay, I've examined you, everything is normal, you don't have to worry. But then the patient is a bit not convinced. No, doctor, my stomach is still paining, even though you have done all the investigation. Okay, right, I will send you. Or for example, atypical chest pain, you did ECG, you have done troponin, you did everything normal. It's, it's atypical chest pain, it's costochondritis. Patient comes back again and again. Okay, right, I will send you to a cardiologist. That's one. And sometimes some of the patients you have to share with other this multidisciplinary care. So you coordinate and refer patients to the allied health physiotherapist, dietitian, okay, sometimes to the specialist. You are managing a patient and the patient's doctor-patient relationship is deteriorating and you're scared of legal implication and refer. Okay, that's the last. And thank you. Is there any question? Those who are sleeping can wake up. Those who are playing with the kids can come back. Those who are going back to clinic, time to wake up.
Thank you, Doctor.
Thank you, Doctor.
Any
Okay,
burning
do you have
question?
any questions for Dr. Kavi?
Hi, Dr. Kumuta here. Wanted to clarify. Doctor mentioned that don't give aspirin in pregnancy, but for PE prophylaxis, we do give cardiprine. Is it like we weigh the benefit
Risk.
of? Yeah.
Yep. Okay. As I said, some of the cases you have to co-share multidisciplinary care. Okay. Those patients, yes, if indicated, it will be prescribed by the ONG specialist, and then they have asked you to continue, just continue. So these are shared care. So it's always when you are prescribing the first slide. All I said, if you look at the first slide, it's again risk versus. Let me go. It's already here. Balance potential benefit of the medication with the potential risk. Consider alternative. So assess the risk versus benefit. If prescribing aspirin for that patient is beneficial, then you can continue with the medication.
Okay, doctor. Thank you.
Yeah, most welcome. Any other
Hello,
questions?
Doctor.
Yep.
Good evening, Doctor. Malini here.
Yeah, Malini.
Doctor, you keep mentioning that when we should try to, especially for antibiotic, right? We should try to choose the antibiotic which is like daily doses and then shorter duration. But whenever we prescribe, we always follow an NAG.
national, okay, antibiotic.
And let's say for
Yeah.
now, especially for amoxicillin, it goes up to like 10 days coverage. So how do we tackle that?
Okay. So you have to, you see, you're in KK and you have limited resources. As long as I say, if you look at the first again, rational evidence-based prescribing, as long as you are prescribing your choice of medication, the best available clinical evidence or established treatment protocol, because you are following that evidence-based and established protocol, because your protocol is national antibiotic guideline. So that is fine as long as you're prescribing, as long as you're telling the patient, this is the indication, you have to complete the antibiotic and why you're giving, that's fine. So you have to look into the case by case, case by say. But this is going to be a short course. The patient needs to understand why it has been prescribed, and then the patient will be compliant. I'm talking about general principles of compliance. Even antihypertensive, you look at the antihypertensive nowadays, it's all there are 2-in-1, 3-in-1 antihypertensive in one capsule, because that helps in the compliance and adherence to the medication. If you give 3 medicine, you ask the patient to take 3 medicine, one in the morning, one at night, definitely the patient is not going to take. Or for that matter, again, amoxicillin 3 times. Okay, whether the patient taking it or not depend upon your educating the patient why you're prescribing and why is it important to take 3 times. We have to tell them about the multi-resistant drugs now. The resistance rising nowadays and difficulty in treating. And you have to tell them if you don't take, if you develop resistance, you might land up with in the hospital, and then in hospital you will be landing up with hospital-acquired antibiotic resistance. So this you'll have a acquired infection, and then again you will have some resistance to that antibiotics given. So if you tell them clearly, then it's okay. Does it answer your question?
Yes, doctor. Thank you.
Yeah. So there's a link there. You can just go into the link and then put in your questions or your feedback, and we'll see how it goes.
Any more questions? You got 3 more minutes. Okay. No more questions. If you think of it later, then you can just use the link, the chat box, and later on I will forward to the respective lecturer. So once again, I'd like to thank Dr. Kavi for his very insightful, very informative lecture. And then we look forward to seeing Dr. Kavi in the next 6 months in a similar lecture. So thank you very much, Dr. Kavi, for your help.
Thank you, Dr. Naveen. And thank you all participants. I hope you have learned, and always remember the 8 steps in rational selection of a drug. Bye-bye. Best wishes. Study well. Pass the exam. And come out in flying colors.
Okay. Thank you very much, Dr. Kavi. And for the other participants, just a reminder, tomorrow program starts at 8:55. So log in before that, because sometimes you need to update your Zoom and so on. Okay. Then you can tomorrow we got 4 more lectures on medical legislation, practice management, professional health, and also a practice audit. All got practice in at the time. Okay, so very interesting lecture, so don't miss it. Okay, at any cost. Thank you very much, and see you all tomorrow. Okay, thank you.
Bye-bye. Thank you.
Hey, bye-bye. Thank you all.
Thank you, doctor.